Today's topic is facilitating adult learning for diabetes and pregnancy clients. Our presenter today is Leona Kilduff.
I have been with diabetes and pregnancy forever, it feels like. I actually was a patient back in 1988. I actually have diabetes and came to this program in that way. And they actually hired me. Scary, isn't it? So a lot of what I speak about actually comes from personal experience and also experience as an educator. So on to adult learning. So adult learning. I'm starting with Knowles. Knowles actually did their work back, it started in the 50s, about the time I think I was born. And it's interesting because this whole area has grown, but the basics are there. So I'm actually only going to do 2 different theories, only because there's many out there. So the first one, Knowles actually looked at the concept of learner. The whole idea that we moved, as we learn things, we moved from dependency to self-directedness. Of course, things like crises, getting diagnosed with gestational diabetes or finding out you're pregnant is a crisis, whether you feel like it is or not. That we actually start trying to move in that direction. Every adult does. In fact, kids do the same thing, but adults tend to only want to learn information that they can use now. The role of learners. They also looked at the fact that we come from our experiences, what our basis is, what we know, our history, our culture, language, which is a huge piece of what we end up dealing with. You know, looking at our history with healthcare. So readiness to learn. So kind of our need to, when we learn, it's our way of coping. You don't learn it when you're not able to cope. So a lot of times, again, if you're in the middle of a crisis, people freeze. That's not unusual. They will eventually start moving. As we learn, though, usually the 2 things we're doing is we're categorizing things, and we need to learn in sequence. The lowest level or the easiest, and you build on that. All piece of adult learning. And our orientation to learning. A lot of times that has to do with the experience we had. Where I work, we have, or where I used to work, I haven't been working clinically recently, we have women who literally never really went to school and clean people's houses to the women who are the engineers in the Silicon Valley, right? It's a huge difference. Their experience of what they learned and how they learn is still all similar, even if they can't write. When somebody's stressed, you don't actually read a lot of times. It's easier to look at pictures, do visuals. Again, a lot of learning is performance-centered. So it's almost easier to learn a lot of the skills, the blood sugar testing and so on. It's a hands-on. You see it, you do it. Usually sticks better than just hearing. The other person, and I can't even pronounce this guy's name, Merzos, the 3 learning domains, technical knowledge, which he calls instrumental, communicative, practical knowledge. Actually, when you read the information on that, that sounds more like what you get from your friends, your family, social support. It's that piece of learning, because you get things reinforced. You don't just learn in isolation. And self-reflection, the emancipatory. So you become independent. It's all a piece of that. One of the things with learning is you also have to figure out what they need to learn, where they're starting at. So I love motivational interviewing, asking where they are, what's going on, and working from there. So it's all client-centered. It's directed. You're trying to direct it in a more positive venue, if possible. An assessment, usually I like this lady. Looks like she's fainting when she's finding out she's got diabetes, right? One of her old ones out of slides. Anyway, so I like to know where they're starting at, what they know about diabetes, what they've been told. I've actually had clients come to clinic appointments. I've never even been told they've had gestational diabetes, which makes it a lot harder than somebody who's doing this one more time. So, or what they've heard from family and friends. I had a mother who had stillbirth. So, of course, the instant I was pregnant, she wouldn't talk to me because she was sure that's what was going to happen. Of course, when she finally did talk to me, I wish she hadn't, because I heard every fear she had and what their fears are. I've had women show up, gestational diabetes, 28 weeks of diagnosis, and they decide they're going to have birth defects because they read it in some book. A friend told them about it and how it's related to diabetes. So kind of allaying some of the fears that may be blocking their learning before you even start. Informational, right? You know, see how they're focusing, working from there. Can they even focus? If they're so upset, they don't focus. What's normal in their life? If I'm going to be making some kind of plan with them, I need to kind of know what normal is. Are they homeless? Do they have a housekeeper who cooks for them? Bring the cook. Again, it's extremes. And usually I try and sit down as we're doing everything, how we're going to fit it into her life. It always helps if they bring a spouse or something, a friend, somebody else who can help them through it. That's that other piece, right, of the communicative, who's going to support them in this whole process. But I want them to be able to perform their own self-care. You know, my theory is if they can do it, and the closer we are to normal, the more normal mom is, more normal baby is. That's what I'm aiming for. So anyway, back to my friend here. I can't pronounce the name of. Merzos. His three learning domains. Instrumental. So gaining technical knowledge. Usually I think of first visit and then follow-up. They're going to be learning it all the way through the pregnancy. It's not all in the first visit. So blood sugar testing, meal planning, we keep adjusting it the whole way through. Communicative, you know, we're trying to see what people are communicating to them, how they tell people what they need, how they deal with friends and family. That's a huge piece of actually doing this whole program. Emancipatory. I do also have, this is a lot of self-reflection, self-evaluation. And you'll find this a lot of times at the beginning. I'll see women who really and truly believe that they were wrongly diagnosed. And so they've decided they need to test it out. I do encourage people, if they really don't believe this, to go ahead and try. I don't want them doing a whole week's worth, but a couple of meals may not hurt. Because it's not unusual to have somebody come and swear they got the wrong test. You know, also, that's at the point in that when we're working at this level where they start to make connections, start evaluating what they're actually doing, what they ate that bothered their blood sugars, because that's a whole piece of learning. They're individualizing it for themselves. So our goals are usually to try and do normal everything. What I'm aiming for is normal glucose, if possible, as close to normal as possible. I want a normal delivery. I want a normal baby size. You know, nice, healthy, right? So usually I'm working with these ladies where first they're acquiring kind of the content, the information, why they're doing this, what this means for them. Technical skills. That's the blood sugar testing. That's your meal planning. And then trying to apply it, how it's going to fit into their life. What's 1 hour after their meal look like? How can they even remember to test? So using phones for timing, using, you know, I used to actually use my client visits because if it was a first visit, it was 1 hour. And if it was second visit, it was half hour. So I had 2 visits before it's time to do a blood sugar. It worked. I've had people use TV shows. Whatever works. You know, I like to give materials in kind of small bites. So we find little bits tend to work better. Give too much information and I find it tends to fall out. There's that whole thing where you hear people saying that you get the first 5 minutes. It helps to kind of change how they see it, what you're doing, kind of shifting gears from written to visual to, you know, hands-on. If you keep it moving, that kind of change helps you remember it again. You know, again, offering content close to when it's going to be used. So when I start talking about postpartum, that's towards the end of pregnancy, not when I first see them. You know, it doesn't help if I'm going to see them at, you know, 13 weeks, I'm going to start talking about the potential of having diabetes later. So close to when they need it. So towards the end of pregnancy, I'll start talking about labor and delivery and baby care. Probably about 35, 36 weeks. I'm not going to do it in the beginning because they're not going to use it for so long that as an adult, it falls out of your brain, is how I say it. Cynthia and I were talking about that. So let me go back. First visit. Everything I'm presenting as far as information and skills are based on the California Diabetes and Pregnancy Guidelines for Care. It was published in 2012. And you should probably all know it's up on the MCH site, and it's also on Cynthia's site, right, down in San Diego. Anyway, first thing I usually do, first visit, it's the basics. All I want them to do is be able to manage themselves. I like to think of it as basic survival, though it's not just basic, it's not really survival per se. It's what they need to at least get them through, get them comfortable with this, because usually the first week's one of the hardest. So I'm telling them why they're doing this. What does diabetes mean to her? Blood sugar testing. And just because she's been a diabetic forever doesn't mean she knows how to test. It's amazing what people do. Basic meal plan. Exercise or activity, right, is what we usually call it. Lowers your blood sugars, or inactivity raises them. And stress is another one. A lot of times exercise and stress I don't speak to all that much because having just what gestational diabetes or diabetes is, blood sugar testing and meal planning is often more than enough for a lot of our women. And you'll start to see somebody glaze over as you're talking to them. So again, basics. And the information and the technical. Technical being things like the blood sugar. How to read a label. So here's our first question that you guys are going to get polled on. If a woman is overwhelmed, what could be delayed until her next visit? I'm thinking of the first visit here.
Okay, here is your question. First answer, stress assessment and blood glucose testing. Second, exercise activity instruction and stress assessment. Nothing can be skipped. It is all essential. Blood glucose and food records, or exercise activity, stress assessment, and meal planning. And let's see here. 5% said we could hold off on the stress assessment. 55% said we could hold off on the exercise and activity instruction. 13% said nothing can be skipped. 11% said blood glucose and food records. And 16% said exercise activity, stress assessment, and meal planning.